Three, two, one. Please start.
Okay. Good evening, everyone. It's my pleasure to welcome you all to today's scientific meeting. We are honored to have Dr. Narmada Ratnasamy, medical oncologist from Royal Care Hospital with us. Dr. Narmada ma'am will be presenting on the topic from MHSPC to MCRPC. Can we delay the inevitable? An important discussion focusing on optimizing treatment strategies and improving long-term outcomes for patients with metastatic prostate cancer. Thank you, doctor, for taking time and joining with us. Over to you, doctor. Ma'am, I will share the slides, ma'am.
Yeah, thank you. And good evening. We'll probably start.
Yes, ma'am. 1 minute. I hope my slides are visible, ma'am.
Yeah.
Yeah. Please, ma'am.
Okay. So thank you for the invite. So today we'll see a very quick discussion on moving from the metastatic hormone-sensitive prostate cancer, navigating towards the metastatic castration-resistant prostate cancer. Can we delay the inevitable process? Slides. And disclosures, these were not my slides, so I've taken it from the payers people. Yeah. So I think to begin with the earlier days, the treatment for metastatic prostate cancer in the hormone sensitive setting, it probably began with archidectomy and first generation anti-androgens. And then later, anti-androgen therapy was not sufficient. And then probably docetaxel was tested compared to only ADT alone. And I think currently we are moving from doublets to triplets. So the standard of care for any metastatic hormone sensitive prostate cancer is ADT plus one of the androgen receptor pathway inhibitor. Irrespective of the timing of metastasis, the risk of disease volume or the burden of disease, and irrespective of the co-administration of docetaxel, plus or minus the local radiotherapy included. So there is no role for intensification with docetaxel alone, as this has been demonstrated by the PEACE-1 data and the Arisens trial. So these were the early intensification strategies which were discussed, which were tested in the metastatic hormone-sensitive prostate cancer. So predominantly, the ADT was that time considered the standard of care. So it was tested in the Chartered and the Stampede series, and in the GET-UG also, comparing ADT versus docetaxel. So there was definitely a proven benefit of adding docetaxel in all the trials, which led to a landmark change in the practice of treating the metastatic hormone-sensitive prostate cancer patients. But I think we have moved on from this to the current era. Next slide. Can you change the next slide? Hello? Can you hear? Hello? Hello? Can you hear me, somebody?
Yes, ma'am. It's audible.
Sorry, I lost you all. Okay. Can I have the slides back? Hello? Hello?
Yes, ma'am, audible.
Okay, I'm not able to see the slides. Can I just discuss just like that?
मैम जिन्होंने शेयर स्क्रीन किया था उनका इंटरनेट अनस्टेबल था तो वो लेफ्ट हो
Okay,
गए
but
हैं।
you people can hear me, no?
पार्डन मैम।
But you can hear me, right?
Yes, ma'am.
यस
Yes, ma'am.
यस।
Okay, so I'll just keep continuing. So next we'll just quickly run through the EAU guidelines for managing the metastatic hormone-sensitive prostate cancer. So the first component of this disease is to achieve a castration, either by medical or surgical castration. And we look into the patient's other comorbidity, life expectancy, and if we feel they have more than 5 years or 10 years of survival, and we look into the disease volume, whether it is a low volume disease or a high volume disease, and their eligibility to undergo systemic chemotherapy, mainly the docetaxel. So if patient is fit enough and we do expect a longer survival and the volume of disease is high, then probably we have to combine ADT with docetaxel as a base therapy. And
Sorry,
if
ma'am.
there is a
My connection got disconnected, ma'am.
no
Sorry.
problem. We'll just continue. So, based on the eligibility, either if there is a very low volume of disease in the metastatic setting, there is evidence to consider even afferent EBRT. I think this was checked with the Stamped and the other Horad's trial and all that. But if there is an eligibility for docetaxel in a high volume disease categorized as more than 4 bone metastasis, one outside the pelvis or vertebrae, or any other visceral involvement. And if patient is eligible for chemotherapy, ideal would be to combine castration along with one of the anti-androgen, and preferable to use docetaxel whenever patient is fit. So currently we do have the triplet combination whenever patient is fit, mainly either to go for the previous generation or the abiraterone with prednisolone, or currently we do have data with darolutamide. And I think we are mainly today focusing on the drug. So next slide. So this is again looking into the data of to understand which patient really benefited from using docetaxel. I think the predominant information is who had presented with a synchronous metastatic disease like prostate plus extraprostatic or other site involvement, and in the synchronous manner, and predominantly the high volume followed by the low volume subgroup had benefited with docetaxel with the hazards ranging from zero point 0.7 to zero point 0.8. But probably in the low volume metachronous population, they actually didn't have much benefit. It probably might have even affected the overall survival if given in those patients. Next slide. So this is again seeing who benefited from docetaxel when we look into the clinical T stage of the disease. So like we were seeing, the higher the disease burden or the T4 diseases, they had benefited by adding docetaxel along with the ADT. Along with ADT as compared to the smaller volume T1 to T3 T subgroup of patients. Next slide. So that's what. So treatment of choice would be to consider ADT uh, along with an androgen receptor pathway inhibitors, irrespective of the volume of disease, the timing of metastasis, and the co-administration of docetaxel plus or minus radiation. Next slide. So this we are looking into the trial, the RSN's trial, which was the only currently available prospective data to investigate the combination of androgen receptor pathway inhibitor, the darolutamide, with ADT with docetaxel in the first line metastatic hormone sensitive prostate cancer patients. So close to 1,300 patients were enrolled with a very good performance status of 0 or 1, and who are candidates who are eligible to receive docetaxel along with ADT, and stratified based on the alkaline phosphatase levels and the extent of disease M1A versus P versus C. So it probably began from 2016, and currently the data cutoff is as of 2021. So in this arm, it was a 1:1 randomization. The control arm was ADT with docetaxel with the placebo. In the experimental arm, it was ADT with the docetaxel 6 cycles along with darolutamide, which was given as 600 milligrams twice daily to be continued daily. And what was looked into was the time for becoming an CRPC or the pain progression or symptomatic skeletal event free survival or first symptomatic skeletal event, time to initiate the subsequent therapy, time to worsening of the physical symptoms, and time to initiation of opioid use for more than 7 consecutive days, and the safety of the drug. And in this trial, so the first cycle of docetaxel was preferably given within the 6 weeks of initiation of the darolutamide drug. That was the one of the inclusion criteria. Next slide. So this, when we compare to the previous study, the mainly the piece one data. So in this, the main thing is there were like 4 arms and there were a lot of amendments which were happening, and it was not directed to test only against the abiraterone versus the standard of care. So it also included some of the recurrent patients. I think close to like 15-20% of patients were recurrent disease. Rest of them were first line metastatic patients, and this also included very good performance status with high or low volume of disease with the categorized stratification data. And the type of castration was also looked into, surgical versus medical. That too, LHRH agonist versus antagonist was looked into. So in this, I think the standard of care, which was initially ADT and later it was amended to include docetaxel as per the data from the previous trials. And then one part was to see the benefit of radiation. The other part was to see the addition of abiraterone to the standard of care, which is ADT plus docetaxel. Or the initial patients had received only ADT as a standard of care. So this was again looking into overall survival and recurrence, radiographic progression-free survival, and the other factors of various survival parameters. And the PSA response was also taken into consideration, including quality of life toxicity, changes in the bone mineral density, and elevation of biomarkers with outcomes. And so this was a previous study, but it was not only focusing upon the role of androgen receptor pathway blocker. Next one. Yeah. So like we were discussing, this was amended. Initially, it was only to include ADT, but when the results of the stamped and charted came back, so docetaxel was as part of the standard of care in the later half of the trial. And so this was some of the amendments which we see as compared to the RSM trial, where docetaxel was part of every patient included in the trial. Next one. So this is again the comparison of 2 trials. So the RSN looked into OS and the PEAS looked into OS and the radiographic progression-free survival. So the extent of the disease, the stratification we are already seen. So the docetaxel was received by 100% of all patients in the RSN trial. Against only 61% had received docetaxel. So definitely this would have altered some of the results, as like 1/3 has not received the drug. And the exclusion criteria for including to darolutamide was any recent cardiovascular events. And whereas for abiraterone, it was along with cardiovascular events, any hypertension which was not controlled with the current medications, rhythm disturbances, and history of any pituitary or adrenal dysfunctions. And whenever patient cannot be taken for consideration for prednisolone, even the lowest dose, they cannot be enrolled in the trial. So this cannot directly be compared, but this is how the history has evolved for these 2 drugs. Next slide. So in the RSN's trial, so the what is the benefit we are expecting at 4 years? Almost like the it's again 50% compared to an increase like by 63%. This was the results at the end of 4 years with the p-value which was significant and the hazard of 0.68. So when we compare the triplet, the ADT with docetaxel with darolutamide. This is what we do expect in the first line metastatic hormone sensitive prostate cancer. Next slide. Yeah, and so this is again an example from piece one where they have shown like whenever we do early intensification of therapy, there is going to be a separation of curves in the earlier itself. So even in this, if we see the docetaxel subgroups, they had significant overall survival improvement when all the three drugs were given with a risk reduction by around 25 percentage with a hazard of 0.75. Next slide. So again, this is again from the RSM data. So where patients in the darolutamide arm stayed in the treatment for more than 2 years longer than the patients in the placebo arm, and had a similar discontinuation rates due to the adverse events as those who had with placebo. So if we see the follow-up is somewhere like 16 months compared to 41 months of the survival benefit we do see. And the discontinuation rates were around like 0.13 compared to 0.10 with the placebo arm. Next slide. So looking into this, I think this is very clear, stating that the addition of darolutamide to the ADT with docetaxel, it did not really affect the ability to complete the 6 full cycles of docetaxel. Almost in the placebo versus the darolutamide, I think it was almost similar, or even it was slightly higher. The completion rates were quite impressive. It's around 87 percentage. Next slide. So coming into the so like we have seen, it did add to the benefit, but it did really add to the side effects also. If we look into the other side, I think in this the adverse event rates were almost similar when we compared to the placebo. So it means the main toxicity were driven by the docetaxel background with the ADT. So if we see like any grade, like grade 1 to grade 5, it was almost similar when compared to the placebo, which means it didn't much affect the tolerance or compliance of the patient. Next slide. So coming to the comparison with the abiraterone, prednisolone versus the standard of care. So this group definitely had some of the cardiovascular, the hypertension rates were severe. So if we see like the fatal adverse events were like 2% and 22% had a grade 3 um, like the hypertension was more than 20 percentage in this group compared to 13 percentage, and I think rest of the things were all attributable to chemotherapy. Yeah, next slide. So this is again comparing the adverse events of darolutamide with placebo. So I think fatigue was more common, but it was seen almost in a similar frequency even in those who just had taken a placebo tablet. And the other side effects were also quite well matched, not really seeing much increase in percentage. Probably there is a slight risk of rashes we may expect. And compared to the placebo, the hypertension rates are high, which is around 13 percentage. But this is again less than abiraterone group, who had somewhere around 22 percentage had hypertension. So compared to placebo, it is high, but compared to abiraterone, it is on the lower side. Next slide. So the standard of care for any metastatic hormone-sensitive prostate cancer, it should be a triplet, probably the first option, or if not fit for docetaxel, at least they should be considered for ADT with the androgen receptor pathway inhibitor. Predominantly, maybe the data is there for darolutamide currently. Okay, and so this is like the current APCCC 2024 panelists, what they had voted for. So in patients with high burden of disease who are chemo fit, so I think the triplet was chosen by 94% of the people. And again, coming to chemo fit, whether it's a synchronous or an metachronous disease, even in those scenarios, I think they had opted for a triplet. So next one. Yeah, so this is what we have seen. Next slide. Next. Sorry. So in the synchronous population, I think there is a predominant, at least the 50% of people have voted to start with the triplet therapy, even if there is a low burden of disease. But if it is a metachronous disease, the proportion of people who opted for a triplet is more. Close to 90% wanted to start with a triplet when it is when it is when they are fit for chemotherapy. Next one. And coming to the safety considerations between a doublet and a triplet, doublet is predominantly in the previous era, it used to be abiraterone. So you watch for metabolic parameters, cardiovascular events, and hormonal changes, hypothyroidism, hypertension, edema, weight gain, hypokalemia, liver function abnormalities. And in the triple negative, you have to consider for docetaxel infusion and the associated chemo-related toxicity and the time for administration and the risk associated with extravasation and post-chemo effects. Whereas in doublet, there is a considerable pill burden and there can be an occurrence of any adverse events because of the hormonal changes which do happen. And there is also a increase in the cardiovascular cognitive effect and the bone health effect, considering these elderly subgroup. Next slide. So coming to the take-home message. So the previously, like we were discussing ADT, and then came the ADT with docetaxel, and then ADT with docetaxel with darolutamide, and now I think there is data for that. So whenever possible, it is important to intensify therapy with the triplet when patient is fit and the volume of disease is more, and to proactively manage the adverse events of the newer options to improve the outcomes, especially the survival, parallelly with the quality of life aspects also. And multidisciplinary care is a key to success. All eligible patients should be considered for the benefit of triplet, weighing the risk versus benefit in each patient's considered individually to enable the living with preserved or an improved quality of life in these elderly males. Thank you. Hello. I think there's a question. I'll take that. So, if a patient progresses despite receiving the afferent triplet therapy, what is your preferred sequencing strategy in the metastatic CRPC? So, I think this basically depends on how long the patient has had a response, whether it was a short response or they had had a good long term disease control and then becoming a CRPC, and what is the age and the medical comorbidities, and what is the site and the disease burden which we have and the PSA values. So I think based on that, we can either put them on the next line, probably with the cabazitaxel if the disease burden is high and if the patient is able to tolerate. If there was a long interval with the previous docetaxel and the current setting, whenever patient is symptomatic and we need a quick downstaging, because back to back changing from one androgen inhibitor to the other one might not be a other good option. And the other thing which is coming up is the radio nucleotide treatments with lutetium and even samarium, actinium, and all is being available in India. So, if it is a bone predominant disease and with a good marrow reserve, even that would be a consideration if pain palliation or if you have to treat more bone disease rather than treating a visceral disease. Even the radionucleotide therapy would be an option in those things. So, next question, in your real world practice, which patients with do you feel derive from the maximum benefit? Okay. See, ideal would be to consider for a triplet therapy. But if we look into our population and the Western population, where they have included the performance status of 0 and 1, versus our population, it's usually starts from 1, 2, or 3, rather than coming with an ECOG of 0. And the age group, we do tend to have little elderly population with multi comorbidities, multiple polypharmacies, normally what we see in the clinics. So yes, there is a subset of patients who might be eligible for a triplet therapy, and especially if they are able to understand the risk versus benefit of adding docetaxel to their initial 6 cycles of therapy, they do well in the long term. So whenever they are like clinically fit and the disease burden is high and they are financially able to manage the chemo related toxicity, I would definitely prefer for a triplet rather than a doublet. But still, the majority of the practice currently is still a doublet. So I think it might take some time for the practice change to happen in a larger volume.
Thank you, ma'am. I think one more question is there. How closely do you collaborate with the urologist and radiation oncologist when
Oh,
decide?
I think I have decided. How closely? Hmm. Okay, so one thing is these days we do see some of the locally advanced prostates also, which is a good thing. Somehow they go for a master health checkup or in some routine random evaluation and they come up with an early stage disease. But when they come with a metastatic HSPC, I think it's very important to integrate the radiation oncology colleagues, especially, and also the urologists, whenever possible, to give them the local prostate radiation if they have a good biology of disease and they do respond to the initial treatment, just like in the peace protocol. Because the local radiation, it helps in control. It may not increase the overall survival all the time, but it does help to achieve a local control of the prostate disease for a long time. And theoretically, in a way, like if we try to control the disease burden in the primary site, it may somehow add up to reducing the spread to the metastatic site eventually, which happens. So I think it's important to integrate them whenever you see a low volume prostate, very fit, able to undergo a triplet therapy. I think it's important to consider them.
Thank you, ma'am. I think there is no more questions in the chat box. Once again, ma'am, thank you very much for joining your busy schedule, ma'am, and your excellent presentation and for addressing the questions from the doctor. And we also hope today's session has provided valuable clinical insights that can be benefit in our practice. A wonderful day, ma'am. Thank you very much for joining meeting, ma'am. Thank you, ma'am.
Thank you so much, and for keeping it very short and crispy. Thank you so much, all. Good night.
Thank you. Thank you, ma'am.
Thank you.